manifestations, which are pain, and the insensate foot, which leads to foot ulceration. And as a consequence, can we play the video? Yeah. We get this, which hasn't really changed from 1901. I think even in San Antonio, they're probably doing amputations the same way. Even more. So, and actually I could stop my talk here, because most people in big pharma think that diabetic neuropathy is a nightmare, because we've got no clear endpoints. So we focus on nephropathy. What do they mean by endpoints? Well, endpoints are the things that you will measure in a clinical trial to show the benefits of a therapy. And unfortunately, my colleagues in neurology are still dinosaurs. Is there any neurologists here? They like to focus on symptoms, signs, and those are not good endpoints for measuring nerve damage, certainly not in a short trial. And so therefore, according to the FDA, progress in the development of disease-modifying agents in diabetic neuropathy is completely stalled. And this was 2013, and I can tell you 2025, exactly the same. So my plea is that we need to change the way we diagnose or measure diabetic neuropathy. So at the moment, we're actually, hang on, let me go back, reliant on rough and ready tools like monofilament examination, neurological exam, vibration perception. And as a consequence, we really are diagnosing or maybe, managing people right at this end stage. So these have to disappear from our vocabulary. And if they disappear, we have to have a replacement. So, 2001, we had a crazy idea that we could measure diabetic neuropathy in the feet by looking at the eyes. And what did we do? Can we just play that, please? Hello? That by measuring nerves in the eye, in the cornea, we could actually get a handle of nerves at that time in the feet of people with diabetes. And what is this technique? Well, it's the technique of corneal confocal microscopy, which is an ophthalmic instrument which ophthalmologists actually use to look at epithelial defects, post-refractive surgery, but haven't really utilized it for neuropathy. And what we do is we scan literally through the cornea. Remember, the cornea is only a millimeter thick, but this instrument allows you live imaging of nerves, cells. And then when you do that, the very first paper we did actually was 18 patients diagnosed according to severity of neuropathy based on nerve conduction, symptoms and signs, into mild, moderate, and severe. And what you see here are the corneal nerves. This is a healthy control. The white lines are the nerves. And this is a patient with more advanced neuropathy. You can see very few nerves. And you see this progressive loss of nerve fibers. So that was 18. And I must say, when I first presented the data, the neurologist said, "You don't know what you're talking about. This is a diabetic neuropathy is a disease of the periphery. How can you possibly tell us that something going on in the eyes can give you any measure?" Well, actually, they have been proven wrong, because there have now been 38 studies. This is when we did this systematic review and meta-analysis, but now there's actually many more, and many more from China. Huge studies coming through from China now, actually replicating what we've shown. And essentially, what these studies have shown is that you can use corneal confocal microscopy to identify nerve damage in people with diabetic neuropathy, but also, more importantly, this group, subclinical early diabetic neuropathy. And AI is all in the news, whether it's ChatGPT or whatever. But actually, we've used AI to look at the images and analyze them using AI. And so what we've done is used various techniques, this logic-based fuzzy inference. And essentially, what it does is it takes the images, puts them through this deep learning process, and quantifies the changes that we see, or actually not necessarily looking at just the nerve fibers, but just looking at as a whole at the image, and somehow does its magic and then differentiates with 100% sensitivity and 95% specificity whether or not that image is from a patient with diabetic neuropathy or a healthy control. And furthermore, differentiates diabetic patients without neuropathy from those with neuropathy, again with very high sensitivity and specificity. And as I said, other people have been doing this. There's a big study called the Maastricht study, which has actually got CCM images from about 3,500 people, with some with diabetes, others with impaired glucose tolerance, and then those with normal glucose metabolism. What have they shown? Well, actually, the same. That is, if you take people with normal glucose tolerance, pre-diabetes, and type 2 diabetes, then actually corneal nerve images, you can see whether or not it's pre-diabetes versus normal glucose tolerance, whether it's type 2 diabetes versus normal glucose tolerance, based on the fasting, 2-hour, HbA1c, skin autofluorescence. There is less nerve fibers in corneal nerve fibers in these people compared to healthy controls. So that was diabetic neuropathy back in 2003. So we thought we'd kind of cracked it, and then we got bored waiting for the FDA to kind of say, well, you know, we ought to accept this as an endpoint. So then we, that's the green, and others have shown that corneal confocal microscopy, when you scan the eyes, gives you a handle of what's going on in the peripheral nerves in people with idiopathic small fiber neuropathy, Charcot-Marie Tooth disease, chronic inflammatory demyelinating neuropathy, chemotherapy-induced neuropathy, Fabry's disease, fibromyalgia, HIV neuropathy, but also Wilson's disease, Graves' disease, amyloid neuropathy. And we've just actually had a systematic review accepted in the European Journal of Neurology of 51 studies looking at all neuropathies, actually, including diabetic neuropathy, almost 3,000 participants, and the bottom line is corneal confocal microscopy in the majority of these neuropathies, apart from a few at the bottom here, does show utility. That is, it can be used to identify nerve damage. And I know what you're thinking, Ralph. No. You're probably thinking, you know what, he's shown me all these corneal nerve loss in all these different neuropathies. How do you differentiate one from the other? Well, we've actually used AI. AI came to our rescue. So AI, what we did is we took healthy controls, people with HIV sensory neuropathy, people with chemotherapy-induced neuropathy, and actually diabetic neuropathy as well, and CIDP. And what you see when you look at these images, whether it's CIDP, CIPN, DPN, HIV-SN, to the uninitiated and even to the expert, compared to healthy controls, there are less nerves here, but you really can't differentiate, you know, whether this is a CIPN individual or a DPN individual. However, vision transformers from the world of AI can. And why? Because they don't just look at, say, the number of these nerve fibers. What they do is they look at visual patterns which are relevant to biology, which look at the texture, the shape, and the spatial relationship between these nerve fibers. And when they do that, this is what happens. You get virtually, actually, really differentiates. You can see 000, 62, HIV sensory neuropathy. It doesn't mistake for other neuropathies. And actually, if you do something called a stochastic analysis, here's what you see. You can see all the people who have these particular neuropathies, apart from the healthy controls in the middle. There's a few it might kind of think, well, that's a diabetic neuropathy, that's maybe a CIDP. But you can see all the others, it really does differentiate each of these neuropathies. So is there anything that we can do for diabetic neuropathy, or do we just diagnose it and commiserate with the patient? Well, actually, there are things we can do. And if you look at risk factors for diabetic neuropathy, what you see coming out is that these are the same risk factors as we have for cardiovascular disease. So these are longer diabetes duration, poor glycemic control, hyperlipidemia, hypertension, obesity, reduced physical activity, and smoking. And there are, of course, many drugs that you can use to modify these risk factors. So one drug that actually works pretty well for most of these risk factors is GLP-1. And we actually did a study. This was my proud moment to have co-authored with Ralph DeFronzo. We did this study, and we actually, it's called the Qatar study, where we took type 2 diabetic patients who were poorly controlled, HbA1cs of 10.5%. This was Mohammed Abdul Ghani. And we basically randomized them to receive once-weekly exenatide with the pioglitazone or basal bolus insulin. And what you see in both groups is there's a reduction in HbA1c, almost normalized to 7%. And then what we did is actually looked at whether or not their vibration improved or whether or not their pseudoscan improved, which are kind of measures that the FDA would accept. What did we find? Actually, nothing. Didn't improve. However, when we used corneal confocal microscopy in these individuals, what you see in both arms actually, that there was increase in these parameters suggestive of nerve regeneration. We've now gone on to actually use semaglutide. And what we've shown is that, as you'd expect with semaglutide, you get reduction in weight, reduction in HbA1c, improvement in triglycerides. Symptoms kind of improve, but vibration, pseudomotor function does not. However, nerve regeneration, corneal nerve fiber length, corneal nerve fiber density improves, and particularly the branch density, which is the new branches coming off these nerve fibers, improves significantly at both 3 and 6 months. We've now also actually looked at the effects of dapagliflozin in 2 studies from India. One called the DINE study, where we took small groups of patients, type 2, and randomized them to either receive 10 milligrams of dapagliflozin, and you can see it reduced HbA1c by 0.53%. And there was a standard of care, which was other therapies other than an SGLT2 inhibitor. And there again, you can see a HbA1c reduction of 0.57%. And we then used CCM. What did we find? Well, actually, in the dapagliflozin arm, there was a significant increase in CNFD, in CNBD, and in CNFL. In the non-comparator group, despite a reduction in HbA1c, actually there was worsening. And in this group, yes, there was an increase in both groups, but this was non-significant, suggesting there's something about DAPA that seems to regenerate nerves. And we've got a follow-up study, actually not from the same center, a different center, again from India, which has got a similar design, which is metformin and DAPA, 30 individuals, and metformin and non-DAPA, 20 individuals. What did we find? Well, if you look at HbA1c, you can see in both arms there is a reduction in HbA1c. However, when you look at the CCM, you see CNFD increases in the dapagliflozin arm, but actually decreases in just the metformin non-DAPA arm. CNBD increases, but decreases in the non-DAPA arm. And again, CNFL increases and decreases in the non-DAPA arm. So there's something, well, we know what's going on actually. We've got some additional studies to show that DAPA seems to be having an impact on regenerating nerves beyond lowering glucose. Painful diabetic neuropathy, well, for pain, small fibers should be more affected. And what we've shown is that if you take people with painful diabetic neuropathy, how much time have I got left? Oh, I've got lots of time, 15 minutes. You find that those with pain, you'd expect to have more damage to their small fibers. And actually, if you look at all 4 parameters, which is fiber density, branch density, length, inferior wall length, in the painful group, they have lower density compared to the painless group compared to the healthy controls. So we believe we have a morphological marker for pain in people with diabetic neuropathy. And furthermore, the amount of nerve loss, and this is in a separate study, we've shown, first of all, actually, we've shown that you can differentiate painful from painless diabetic neuropathy with reasonable sensitivity and specificity. So you take a diabetic patient, you split them into painful and painless, and actually you get reasonable AUCs. Furthermore, if you look at the severity of pain, there is no pain, mild pain, more severe pain, you see a progressive loss of corneal nerve fibers. So, of course, the treatment of painful diabetic neuropathy, well, much hasn't changed in the last 30, 25 years, actually. What we have are different targets. So we have targets at the periphery, targets along the spinal cord, and targets in the brain when we are treating painful diabetic neuropathy. Of course, we know that the primary lesion is peripherally, but we also now know that there is major modulation going on at the spinal cord level and also at the brain level, which is why a lot of drugs work at these at the brain and the spinal cord level. So for the periphery, we have treatments like capsaicin, local anesthetics, even on anti-inflammatories actually do work to an extent to reduce pain. Again, if you look at the brain, there are drugs that work on the ascending pathway, including pregabalin and mirogabalin tricyclics, tramadol, and opioids. And there is a descending modulatory pathway, which puts a brake on these signals going up that also modulates, and this includes the SNRIs, the tricyclics, tramadol, and opioids. So what's the evidence that any of these drugs work? Well, actually, maybe the best evidence to date is a study published in The Lancet 3 years ago. This is comparing the three big drugs, amitriptyline, pregabalin, and duloxetine. What happens? Well, not very much, actually. What you see is, yes, all three drugs seem to work, but if you look, pain score of about 6 gets down to about 3. So what's that telling you? Well, about 50% reduction in pain. Not particularly effective. So is an NRS of 3 adequate? I don't believe it is. And I think we need to think about new targets for painful diabetic neuropathy now. So what are these new targets? Well, potentially, actually, they are going to come from the sodium channel, which is expressed on the periphery, right? Not at the spinal cord level or not at the brain. And I must say I was a skeptic about genetics being the answer, but I got involved in a big study called the ProPain study, which was run out of Europe, where we looked at mutations for these sodium channels. And what we found, surprisingly, is that actually there's about 21% of people with painful diabetic neuropathy have some kind of variant, either in the NaV1.7 or NaV1.9 channel. And there are other smaller numbers, I think, of mutations, actually, again in a big cohort, of various other ion channels which are being expressed in the periphery, whether they are hydrogen channels, potassium channels, TRP channels, that we do identify mutations for painful neuropathy. And we now actually have a drug called suzetrigine, which is a voltage-gated sodium channel 1.7 modulator for peripheral neuropathy. The big thing to note is that VX548, when it's being tested against pregabalin, okay, which is a very effective therapy, I would say, what do we find? Well, comparable reduction in pain to pregabalin. However, the key differentiator is this. If you look at pregabalin, look at the side effects: weight increase, headache, dizziness, somnolence, which we all know limits the dose of pregabalin. However, look at the sodium channel blocker. Very little in terms of side effects. So I believe the future will be these targeted therapies that will have less side effects and equal or maybe more efficacy. And actually, this is a paper that's now looking at how these voltage-gated sodium channels may not just be modulated with agonists on the receptor surface, but actually intracellular alterations, and this is FGF13. So this is a paper that I'm kind of somewhere, I don't know, somewhere in the middle. And actually, I know, Ralph, you've got lots of JCI papers. I realized how difficult it is to get into JCI. We spent 2 years repeating experiments, sending it back, and they still weren't happy, and eventually we got it in. But so basically, this is actually a huge number of experiments that we did to look at how FGF13, which is expressed intracellularly, could modulate NaV1.7. So we had to do an experiment to show that TRPV1 activation modulates FGF13, which then modulates NaV1.7. We then used a complex stabilizer to increase the expression of FGF13, which we know then had an effect on NaV1.7. We then had to do another experiment where we overexpressed FGF13 and we found that this had an impact. And eventually we had to use a complex disruptor to actually again modulate NaV1.7 and show that it actually has an impact in terms of pain modulation. So what you see here are, NaV1.7 or different channels, FGF13 intracellularly interacts with these channels and brings them inside, and you have normal nociception. In pain, what happens is when these FGF13 molecules actually attach here, you get increased activity. However, if you use a disruptor and you block this, you can then get reduced pain nociception, and that's now going to go into clinical trials. But sometimes obvious conditions that the treatments are the most difficult, and that's maybe relevant to Dilek's talk on vitamin D. What we've actually shown is that vitamin D is really quite important in terms of the painful diabetic neuropathy. So those with pain have lower levels of vitamin D compared to those without painful neuropathy. And the odds ratio, if you have a vitamin D level less than 20 nanograms, you have an odds ratio of almost 10 of developing painful neuropathy. Even 30, which most people feel is normal, is 5-fold increased risk of painful diabetic neuropathy. This is our study in Manchester. This is a study in Sheffield, which actually showed exactly the same. Lower levels of vitamin D in those with pain. We then did a study where we gave intramuscular vitamin D3, and what we showed is an impact on pain, which was as good as pregabalin, gabapentin, and duloxetine. And we also, if you fail there, then there is also now the possibility of using spinal cord stimulation. This is high frequency, not low frequency, and this is a study that's been published in JAMA Neurology in 2021, where you see conventional medical therapy against spinal cord stimulation. This is conventional medical therapy. And remember, 6 to 3. This is spinal cord stimulation. 7 down to 2. Very, very effective reduction in pain, but also sleep. And you can see this is basically showing you the responders in conventional medical therapy, very few, 85% responders in the spinal cord stimulation arm. And actually, in a small study, what we've now shown is that if you can really, really get a reduction in pain, then it may have an impact on the underlying disease itself. So this is a study from Nigel Calcutt's group in San Diego, where they took people and they looked at the VAS score, and you can see VAS score starting minus around 5, it gradually kind of came down. But then, in addition to reduction in various aspects of pain, what they've done is looked at skin biopsy in the foot, and they show actually a regeneration of nerves and CCM, an increase in nerves. So relieving pain may be having an impact. And we've now just done this big TriNet exon analysis actually to look at, because these are small studies. So this is now over 3,000 patients who've had spinal cord stimulation in a number of institutions across the US and Europe, compared to 3,000 people who didn't have it but were on maximal gabapentin and pregabalin and or duloxetine. What do we see? Well, actually, this is not a cardiovascular outcome trial, but it is. Because if you can get effective pain relief in people with diabetic neuropathy, look what happens to the MACE events. As good as any antihypertensive, as good as any statin, as good as any SGLT2 inhibitor, but we're actually seeing a reduction in MACE, mortality, amputation, and even suicide risk. So really, pain is a big, big issue that, I think we need to address much more kind of aggressively. Okay? I'll just finish off because Ralph talked about central neurodegeneration. So is there a role for CCM in central neurodegeneration? Things like dementia, Parkinson's, schizophrenia, multiple sclerosis, epilepsy. Well, actually, could you just play that? If you look, the cornea's here and the brain's here. And the grey matter that Ralph talked about is not very far from there. So, do we have evidence that CCM could be useful for Parkinson's disease or dementia or multiple other central neurodegenerative diseases? Yes. So we've actually looked at CCM in controls, people with mild cognitive impairment and people with dementia. And what do we see? This is actually a big Chinese study that I was involved in. There is a progressive loss of corneal nerves in people with dementia compared to MCI, compared to those who are cognitively normal, compared to healthy controls. This is actually in Parkinson's disease, but we've also got a separate study in dementia, just without. And what we also show is the MoCA score, which is a marker of cognitive dysfunction, correlates beautifully with corneal nerve fiber density, with high sensitivity and specificity of 86% and 96% for differentiating those who are cognitively normal from those who've got dementia. And we've done a longitudinal study over 2 years where we've shown that not reduction, but loss of corneal nerve fibers, branch density, length, hippocampal volume, whole brain volume. But CCM predicts those who have got mild cognitive impairment who go on to develop dementia. So we've shown it in multiple sclerosis, actually, dementia, autism, schizophrenia, that CCM can be used to identify neurodegeneration in these different conditions. And I know what you're thinking. Can it differentiate, CCM differentiate MS from PD from dementia? Yes, it can. And this is actually using a different AI algorithm, but looking at people with MS, with PD, with dementia, and what we show is that it can classify each of these different neurodegenerative diseases with very high sensitivity. Parkinson's disease was 100%. MS, slightly less, but still very good, and dementia, just as good. So the future, I believe, is going to be healthy people are all going to have a CCM. And AI is going to help us to say, you lot are normal, which are going to be very few, I'm afraid. But there are some who've got some kind of neurodegenerative disease. And we're going to use AI again to actually identify whether they've got diabetic neuropathy or dementia. And did you notice that suddenly changed, the photograph for the CCM? Do you know why? Because now that, you see, is the new T3 Chinese CCM is coming. So they've started making it, and they have big plans to kind of really kind of, take over the world. Gauche, within 3 months of developing the device, they'd got approval from the Chinese FDA, and they now have actually gotten for an EU approval rather than the FDA, because we know what the FDA will do. So, the eye is the window to the soul and beyond. Thank you.